everyone. Thanks so much for joining. My name is Aya. I am a Jedi co-chair at AOCPMR, and welcome to the roundtable this month. So we are just going to get started with the community agreements before we really dive into tonight. So this is something that new that we've started doing. Shout out to Nathaniel for putting this together. But it's really just a set of framework for how today's going to go, especially since we are the Jedi Committee. And we have some really great topics to talk about. So essentially, today we are planning to be present and engaged to speak our truths. If things get uncomfortable, just embracing that and expecting and accepting non-disclosure and honoring confidentiality. Again, this is a space where we take space and we make space, and giving grace to ourselves and others is very important. And just that basic understanding that we all have something to contribute to the conversation, and respecting that. And then what we have on the right here is the QR code for our feedback form. So if you have any feedback for today's presentation or any other Jedi event, please feel free to take a quick picture and let us know. All right, so today we are having an International PM&R themed Rehab Roundtable. So if you've never been to one of these before, we have 3 student presenters from all across the country, and everyone will be presenting a specific article that is centered around global PM&R, however that might look like. And we're going to watch their presentations, ask and engage with them, ask them questions, engage with them, and learn a lot. So without further ado, we have our speaker for tonight, our moderator, Dr. Ala Abu Mahfouz, who I would like to introduce. She is an alumna of the Wayne State University School of Medicine and has actually just graduated from her PM&R residency at the Detroit Medical Center in the Rehab Institute of Michigan. So a little round of applause for her. She enjoyed general rehab, and she is going to be soon joining a private practice group where she's going to be managing inpatient, outpatient patients, as well as doing consults. She has an interest in global rehab and has previously presented on this topic. So we are very excited to welcome Dr. Abu Mahfouz tonight.
Thank you guys. I'm really excited to be here. I'm excited to hear the presentations and have like a conversation about this topic. It's something I really, really enjoy.
We're super excited. I'm just gonna get started and stop sharing my screen and allow our first presenter, Shreya, to get started.
Good evening, everybody. My name is Shreya Avernani. I'm a third-year medical student from MSU Com. And real quick, before I get started, I just want to take a moment to thank AOCPMR JEDI Committee for this amazing opportunity, and then also congratulate Dr. Abu Mahfouz for just graduating residency. Tonight, I will be presenting on the current rehabilitation challenges in the Gaza Strip, as well as the need for a coordinated response. The original paper is a policy brief published in the Journal of Public Health Research. So our presentation will focus on breaking down that plan that the authors propose for rebuilding Gaza's healthcare system, including physical medicine and rehabilitation care facilities. So first, let's just talk about the problem itself, and some of the many reasons why implementing a solution will unfortunately be very difficult. Tonight, our discussion is going to focus on the 2-year period detailed in the original paper, October 2023 to October of 2025. But I do think it's very important to address the conditions prior to this period, which contribute to a lot of Gaza's challenges today. Gaza's healthcare infrastructure has been weakened over multiple years from greater systemic challenges, the most apparent being the violence from occupational forces, as well as strict blockades at the borders. Transporting adequate medical equipment, getting experienced personnel, and getting the crucial humanitarian funding through Gaza has always been a long-standing problem for not just Gaza, but all of Palestine. And as if this wasn't a dire situation already, you now enter this 2-year period, which the paper focuses on, in which the violence has escalated heavily. The hospitals still standing are under severe distress, as you can imagine, and now in one of the most densely populated areas in the world, less than a third of rehab facilities currently stand, but none of them are fully operational. And what we're seeing clinically is an epidemic of complex multi-regional blast trauma. In this 2-year period, the World Health Organization estimates about 42,000 people in Gaza living with one or multiple catastrophic life-altering injuries. So your severe limb traumas, your spinal cord injuries, TBIs, major burns. There have also been upwards of 5,000 limb amputations, with one in every five of those cases being children. And because emergency services and acute surgical teams are completely overwhelmed by just trying to save lives, chronic management and, of course, early rehab have just been completely paralyzed. Currently, we do have multiple local and international humanitarian organizations who do recognize the challenges that Gaza is facing today, and they are providing aid to the best of their ability. Here are just a couple of the larger organizations and their respective efforts, but in the context of the barriers that we just discussed, these efforts are just not enough in terms of volume. There are also more individual attempts at trying to make a difference, but as the paper notes, what Gaza really needs is to be rebuilt, right? And doing so is going to require a unified national recovery framework, um, as opposed to these, more fragmented efforts, which are just failing to meet Gaza's immense healthcare demands currently. And so here's just an overview of the recommended coordination model that the paper talks about. It would be ideal to have a UN-led rehab and recovery task force within these four domains: um, clinical rehab services, infrastructure, supply chain, and workforce. And we're going to talk about each domain separately at the rest of the presentation. Um, but ideally, it would be nice to have an operational lead and their own task force, like each of these four domains, who would first make a 6-month operational plan detailed with appropriate performance indicators, given their respective plans, and just a more transparent system that tracks the financial donations coming in from individuals and organizations. And of course, we'd need a lot more than just a couple of minutes to really discuss the details of their plan and how it's going to play out over the long term. But this is just a quick overview of what each of these four domains would strive to accomplish, hopefully, and where each of the organizations in the prior slide would kind of fall under this meshwork. The clinical health services domain, just like what it sounds like, is going to be in charge of reestablishing clinical and rehab services on the ground in Gaza. Currently, it's the World Health Organization that does that. They're the ones who emphasize the rehab coordination with the emergency medical teams. So under this model, they'd be perfect for conducting these larger scale rehab needs assessments, establishing clinical protocols, and then connecting the remaining healthcare establishments, the ones that still stand, into a larger, integrated system, which, to build the communication with one another. And their initial rehab packages would ideally include mobile wound care teams, rapid prosthetic fittings, tele-rehab, and a training program for local providers, which these last 2 points we will talk a little bit more about at the very end. Obviously, the hope is to rebuild every structure that's been raised in Gaza since the occupation, but this model just refers to rebuilding the hospitals as well as systems that have direct impacts on public health, right? So that's namely restoring sanitation. As you can imagine, the lack of clean water and damaged sewage systems, all these directly affect well-being, right? So fixing them is just as important for long-term health outcomes. The plan hopes that MSF, or Doctors Without Borders, could contribute to rehabbing Gaza's infrastructure similarly to how they did in Somalia through their Green Initiative project. They were able to transition hospitals away from diesel generators to solar-powered systems, which lowers operational costs, but also in Gaza specifically would help bypass a lot of the checkpoint restrictions. Additionally, it would be nice if the United Nations Developmental Program and the World Bank coordinated in that reconstruction of health and water infrastructure in terms of the long-term financing until local healthcare and municipal structures can sustain themselves. Supply chain, it goes, hand in hand with infrastructure pretty much, but that is referring to more like the transportation of the essential goods into Gaza. Many of the organizations working now, including UNICEF and the United Nations Relief and Works Agency, their focus primarily has been on bringing the basics into Gaza, like food and cash distributions. And the hope is that these organizations under the UN's authority can keep doing that, but under much larger volumes that will actually support the population through the Rafah border crossing with Egypt. And all the like checkpoints that come after that, without being stopped or seized anywhere. Lastly, but arguably the most important to bringing this plan to life is the workforce that all these projects call for, right? Gaza's workforce is, of course, extremely drained across all the industries, and the paper solution is primarily rooted in engaging the Palestinian diaspora. They believe that implementing certain measures is going to help encourage emigrated Palestinians to safely return and contribute. So you can see some of the examples that they listed, setting up a portal for short-term assignments, fast-tracking international credentials, grants for diaspora-related rehab enterprises, and partnerships with universities or companies who can help coordinate mission trips. I do want to add here that I think the authors of this paper just assume that engaging Palestinians abroad is a more practical solution in terms of getting enough people together who care about rebuilding Palestine. But with these last few minutes I have, I really do want to emphasize why I think all of us should care about what's happening in Gaza and, of course, international PM&R as a whole. Um, I'm sure a lot of you know this already, but the origins of physiatry come from very similar conditions post World War II, right? All these soldiers and injured civilians needed to be reintegrated into society, and the four founders of PM&R were at the forefront of that initiative. And now, 80 years later, we have 2.2 million displaced people who are in need of very similar rehabilitation services, but just don't have them. And so who better than physiatrists of the future to be at the forefront of addressing Gaza's rehab needs, right? Um, and now I just want to wrap up with a couple of action items for all of us as both medical students and then future physiatrists. First and foremost, it's really, really important that we continue to advocate for the end of violence from the occupational forces in Gaza and throughout Palestine. It's also very important that we acknowledge that as American medical students and future physiatrists, we do hold immense institutional privilege, as well as, access to a lot of resources and funding that can be leveraged to support these networks directly on the ground in Gaza. Or also, we can take that initiative to directly engage with a lot of these organizations like the International Society of Physical and Rehabilitation Medicine, who has their own committee for a rehab disaster relief. There's also a lot we can do from here, like from the States. Like we mentioned earlier, integral parts of those rehab packages that they want to introduce include telerehab and establishing these training programs to produce local PTs, OTs, speech therapists, prostheticists, or any other trauma-informed providers, right? And evidence from a lot of systemic reviews show that telerehab is safe and a great means of promoting these functional gains in areas where in-person services are just scarce or, in Gaza's case, very difficult to render. Also, educating those on the ground in Gaza, I think it's a very empowering thing for families and local workers to support that kind of functional recovery that we hope to bring as physiatrists to their communities. Um, and people for both of these initiatives, they can come from anywhere, right? Um, so if there's one thing that you take away from this presentation, it's that I really hope that you guys consider donating your time or efforts now as medical students or later on as residents and attendings to, some of these action items. Um, but that's all I have for tonight. Thank you all again so much for being here. This is a QR code for the original paper. If you guys have the time, I would highly, highly recommend just checking it out. It's a great read, but that's it. And I guess now we can open it up for any comments or questions about this presentation.
Thank you so much, Shreya. That was a wonderful presentation. I think you saw all of the applause that we're sending you here on Zoom. And I love that the tie back to what we can do as medical students and hopefully as future attending. So, Ada, I'll let you, Dr. Mahfouz, I'll let you carry it on if you see anything you'd like to ask Shreya.
Sure. First of all, I also wanted to give you an applause. I couldn't find the applause, but I'll tell you. So, great presentation. Something I really like that you mentioned that, was on my mind while going through some of these articles and also just in general when I think about this topic is how new the field of physiatry is in general. You mentioned that, in the United States, it really was founded after the veterans came back from World War II. So it's still a very new field. So you can imagine in other parts of the world, it's not even recognized at all, which presents like, obstacles, obviously, because then it's harder to give that kind of care to people. What did you, when like reading the article, what did you imagine was some of like, some of the challenges we might face in trying to implement these things? This is kind of an open-ended question, I guess, like just to get some brainstorming.
Is it cheating if I answer first, or should I give other people time
You
to
can
think?
answer. Go for it.
I guess, well, okay, elephant in the room. This is a very like public health oriented paper, but of course, a lot of these things include policy change, right?
Mhm.
So I think that's the biggest thing, right? Like, yeah, it's pretty self-explanatory that a lot of these things, bringing all these resources into Gaza, like allowing a lot of the medical personnel, both those who have like Palestinian origins and then everyone else, right? That has always been a challenge to my understanding.
Yeah,
So I think that's the biggest thing, just getting more involved with the like policy change side of it, right?
absolutely. Absolutely. That's definitely one of the biggest things I always think about is like, policy change and then the logistical factors of like, how are you going to get volunteers in? How are you going to get supplies in? I remember when I was like researching this topic with regards to Gaza, but also with regards to like other I've looked at into it from like in terms of like other world disasters, like for example, earthquakes, natural disasters in other countries in the world. They also result in like huge numbers of calamities essentially, and these patients a lot of times need have a lot of rehab needs. But yeah, I always used to think about like aside from getting the personnel, the equipment, I sometimes even imagine things like imaging, like CT scans, MRIs. Like, what if you want to see you know, you want to evaluate somebody's like cervical spinal cord because you're concerned about like an injury there, but you don't have an MRI to see like the extent of it. You know what I mean? So I always wondered, even things like imaging, supplies in terms of medication, supplies in terms of orthotic devices and prosthetic devices. It's just such a big, like when I think of all of those factors, I think that those are such huge obstacles to people getting proper care. But I did really enjoy that paper a lot because I liked how they basically specified multiple organizations and each organization taking on one role to essentially come together to like provide all that care. I don't know how easily, I mean, it's like a proposal plan essentially. I don't know how easily it is to be implemented, but I think this is the beginning, right? Is to plan and try to come up with an idea and then later on execute it. But so it's a very interesting topic. It's a very interesting topic. Does anybody else have anything to add? Any questions? Any comments?
I actually did have a thought about this as well. I think that one particular, I don't know if I'd necessarily call it a challenge, but I think something to maybe be aware of too is that this is something that also takes a very, very large mental toll on everyone who is in Gaza and who is affected. And so maybe something to keep in mind when providing support, providing training, is that we need to strike a bit of a balance as well, and kind of take a cue from what the population themselves needs and what in terms of like the pace that we go at and the involvement of locals as well.
Absolutely. That's actually an excellent point too. It highlights a couple things. Number one, it brings into light one of the points that Shreya mentioned in her article, which is involving people from the Palestinian diaspora. And I think that helps with, a lot of times like having that cultural understanding of at least, the baseline culture, and you can possibly understand the people more and help them cope a little bit more in that sense. And then I think the other thing that this brings to my mind is, in the US, if you go to any inpatient rehab unit, or like you're going to have it's a multidisciplinary field, right? Our field is so dependent on like a lot of people working together. And a lot of the time, the physiatrist is the leader of that team, right? And then you have your physical therapist, your occupational therapist, your speech therapist, neuropsychology, case managers, nursing. It's a whole team effort, right? So, the point I'm trying to get to is actually neuropsychology is always like a really big part of that team. And especially even in the US, for example, even though a lot of patients are not coming in due to conflict related issues, but they're coming in because of traumatic events in their own lives, be it an accident, a violent event that led to a disastrous injury. And a lot of the patients do end up having, suffering from like acute traumatic stress, that kind of thing. And you can only imagine in a setting like Gaza, where this has been ongoing for like over 2 years now, that I mean, we can't even comprehend the level of psychological distress these people are under. So that's definitely a great point. And it just highlights if these efforts are implemented, the multidisciplinary need and the need for like more staff, like neuropsychological staff and psychological counseling, that kind of thing. It all plays hand in hand. And you'll learn, if you guys are all interested in PM&R and you do your rotations, you'll learn that like a lot of times with like functional outcomes, the patient's own motivation, the patient's own like showing up every day and participating plays a huge role, right? Because if we see patients sometimes who like have spinal cord injuries, for example, and they're so shocked by what happened, they can't comprehend it, they're upset, they're refusing care, they're refusing medicine, they're refusing literally everything. They don't want to see a therapist, they don't want to do therapy, and obviously that is going to impede their recovery. Understandably, they're going through a lot of things, but yeah, that's a great point to mention, that it can definitely have an impact on somebody's participation and overall functional recovery and outcomes.
Thank you all. I'm sorry to interrupt. This is a really great discussion. Just before we move to Noor's presentation, I do want to highlight a comment in the chat. Thanks, Nathaniel, for pointing out in addition, just the idea of having a famine and such low food access and clean water access, right, in Gaza. I mean, we talked about last month how energy expenditures just increase so much, whether it's a lower leg amputation, is it above the knee, below the knee? I mean, it was really something shocking, that at least personally, that I learned last time. So thank you all for your discussion. We're going to move on. Noor, I'm going to ask you to screen share, and we're going to hear another awesome presentation.
Just like Shrey, I just want to thank everyone who was a part of this for giving me this opportunity to join in. I had a lot of fun putting this together. So I'm really glad actually that Shreya went right before me, because we have similar topics. I'm also presenting on Gaza, but I'm more so focusing on the emotional social aspect. So I feel like this is a perfect segue, straight from the physical, what we see, to the social emotional, what we don't see and what we often forget to acknowledge. And my name is Noor Ghazali. I'm a second year at Michigan State University's College of Osteopathic Medicine. Okay, so before we begin, I just wanted to kind of go through organize what I'm going to go through. So first, we're just going to go over the crisis, the genocide in Gaza, go through some background on that, and then talk about the article, highlight the main points, and then circle back to the JEDI DEI portion and what we can take from this. So the article of interest was from the Journal of Social Science and Medicine, and the article is titled Structural Violence, Disability, and the Struggle for Dignity Among Disabled Women and Girls in Gaza. And I had a really, really great time reading through this. It was written like beautifully. It was almost like a narrative or like a story. It was very interesting to see the thoughts of the people who are affected, and I would highly encourage you, even if you don't have the time to like read through all of it, just read through the results. It's organized in such a beautiful way that you can just hit the highlights and you still get everything. So some background, Gaza, the city in Palestine, is facing an ongoing humanitarian crisis since the occupation due to Israel, and this whole crisis, or you could even say genocide in general, has escalated since October 2023. So some of the results of this have been the absolute demolishment of healthcare infrastructure, shortages of essential resources, and then the displacement of civilians back and forth, having an unstable environment to be in. And not only does this have a physical toll on the people who are affected, but it does put an immense emotional strain on them as well. And so through this article, they specifically look at the intersection of gender and disability-based discrimination and how they work together to amplify the hardships that women and girls with disabilities in particular face under structural violence. And I put this little image at the bottom to look at how we can't just isolate one variable and expect to treat off of that and see improvement. We kind of need to look at everything. Everything has an intersection, and this is this article is very heavy on looking at the intersection between the two variables. So more on the background, an interesting statistic that I found was that prior to October 2023, we had seen 58,000 individuals with disabilities in Gaza, and women and girls made up 45%, which is about a little bit over 26,000. And that is just an immense, a crazy amount for such a small area. Like Gaza is not that big, and this is a very absurd amount. And that's just something to acknowledge while we take a look at this. It's affecting most of the population. And then the article does mention it did not want to exclude, only women and girls face these struggles. There are parallel yet not equal experiences for men. For example, men with disability, they will face limitations to becoming the breadwinner, for example, and that can come with loss of status, altered family dynamics. So that is something to keep in mind. They have very similar but not equal, and we can't really put men and women's experiences together. So this is why the article kind of highlights only one of them. So the main objectives, the article sought to look at how structural violence impacts women and girls with disabilities in Gaza. And it was focused on answering these three main questions and how they experience structural violence under the conditions of this genocide. Two, how we can look at the intersection of gender and disability to see how that impacts not only physically, but socially and emotionally these people. And third, what do women and girls with disabilities do about it? So the methods, this was a qualitative study because they felt that it was the best way to capture the individual experiences of each person without kind of just putting it into these standardized blocks. And it was of 30 participants of women and girls with disabilities who were displaced in Rafah camps. And another interesting statistic was that 10 participants of the study, so 1/3 of the participants were under the age of 18, so they were minors. And as you go through the article, you kind of really appreciate how mature these young women or young girls are and how the genocide takes a toll on maturity and how they have to grow in such a short amount of time. You really do appreciate that, and it's very interesting to see. So each participant was structured, and then they were translated from Arabic to English, and then they employed thematic analysis to identify major themes, and they received an excellent intercoder reliability of Cohen's kappa 0.94. That's quite reliable. So moving on to the results. So as I had mentioned earlier, the article does a very nice job of putting the results into 6 main topics. So these are the 6 main themes that were seen throughout all these interviews. So the first one was the loss of mobility and assistive technology. And I would really encourage you to read the quote as I kind of just talk about it, because they are very profound and very interesting. So this quote is talking about how the genocide, which has caused them to have disability, is producing a physical barrier that prevents them from being fully autonomous and shifts their once basic human needs to now privileges. So the dependence on physical devices and assistive devices, even that is not even accessible anymore because, for example, in this quote, she says, I can't even get my blood pressure medication Like these things that we take for granted are not even accessible there. So that's something that was one of the major themes throughout all of these participants. Another theme was stigma, social death, and the pain of abandonment. And then this quote is talking about how the societal norms have been kind of destroyed due to her disability. For example, who would want to marry a girl who can't hear? And this talks about how, looks at how women women and girls with disabilities are essentially marginalized and isolated from society. And this infringes their ability to form connections their with people in society, which we often, when we don't when we don't acknowledge this, we often forget that yeah, someone has a physical disability, but you also have to look at the social emotional aspect, and if they're undergoing social death. In this article was talking about how they are just fully cut off because nobody wants to be around them due to their disability. The third theme was the rupture of family and erosion of intimacy. In this quote, they talk about how this woman's fiance had left her because of her disability, because he felt that she needed more care. And we can see the altered family dynamics and relationships and how this changes um, the traditional gender roles. Because in Gaza, you can infer from this that women are expected to be the caretakers. And when it kind of flips so that the man becomes the caretaker, it puts an immense stress on the relationship, and it's just very difficult to navigate. And this eventually leads to social and emotional abandonment as well. And then fourth, systemic exclusion from care, education, and participation. In this quote, she talks about how her disability prevented her from being able to receive an education. Not only is it due to her disability, but it's the unwillingness of the system to provide accommodations. So structural barriers inhibit those women and girls with disabilities from receiving not only health services, but education and being able to become a participating, valued member of society as they're stripped of that identity. And then fifth, the assertion of agency and emergent solidarity. In this quote, she talks about how she forms her own informal support groups, and she advocates for herself due to her hearing loss. She forms this kind of group where she teaches others sign language. And these women and girls with disabilities are very strong. They are adaptable, and they use this as a form to resist marginalization and prevent their identity from being taken from them. And then lastly, persistence, hope, and the reconstitution of value. In this quote, she refuses to let her disability define her, and she identifies her own value. She's repairing her own self-worth. And then a lot of the women in the other quotes in the article, you see that they are redefining feminine roles. It's not always that women are going to be caretakers, etc. They're going to find a way to still be themselves, be true to themselves. And most importantly, we see in this article that these women and girls with disabilities are forming connections through their shared experiences to allow them to be a source of empowerment for themselves and for each other. And then a quick little lessons that we can learn from this. Care is not a one size fits all. We need to take a multifaceted approach, as we need to acknowledge intersectionality of gender, disability, everything, so many other factors. And we need to be able to look at that and then see how that can stigmatize people with disabilities. And then those with disabilities, they require equitable access. This is, oh my God, sorry, require equitable access to resources and services. So we can't just, like I said earlier, we can't just do a uniform approach to each person. We really need to individualize care. And then that leads to my third point. We need to look at physical disability beyond just the physical limitations. We need to look at how it plays under the role of structural violence, and we need to acknowledge that, as well as providing basic necessities. And we need to be, like Sherry had said in hers, we need to make sure that these people are set up with psychiatrists, and whatever else they need to take that emotional burden off of them as well as that physical burden. And then finally, in order to empower these marginalized groups, we need to start systemically, not only fix the surface. We can't just put a band-aid on a gunshot wound. We need to look from the bottom up. And through that, we need to acknowledge diversity, equity, inclusion, and justice. So yeah, we essentially what I'm getting from this is that we can't just say, oh, this person has a physical limitation. Let's look at it from a physical aspect. We are osteopathic physicians and we're healthcare workers that we need to acknowledge every single aspect because there's no way in life that one variable is always isolated. So we need to acknowledge the intersectionality of all of that when providing care. And that's it. Thank you guys.
Thank you so much, Nora. That was a wonderful presentation. And Dr. Mahfouz, I see you found the applause button, so I will let you take it away.
I did. I found it. That was that was a fantastic presentation. I really liked two things that like stood out to me that I really liked. Number one, I like that it highlighted that there are people with pre-existing disabilities in a lot of these, in a lot of natural disasters, genocides, conflicts. There's a lot of people who have these pre-existing disabilities, and aside, they're going to be struggling to get the care they need, the maintenance they need that they typically had from before. Even in disasters like in the US, there was like Hurricane Katrina. I remember reading about that. And there were people who died because, they were disabled. They couldn't evacuate their homes in time. So like that's something to think about with people with disabilities. Not only do, like the genocide in Gaza, not only do things like that create new disabilities, but then there's people with pre-existing disabilities who are going to, struggle to evacuate areas or struggle to get the care that they need, that they have been getting. And you mentioned the example of the lady who had a wheelchair and she just couldn't get the maintenance that she needed. So that was a great point to keep in mind. And then the second thing I liked was the psychosocial implications and how that can affect the patients. It made me, that story, all of them were pretty devastating, but the one where like the fiance left her because he said, I don't want to take care of somebody with this. That's something we see even like, not just in disaster settings, it's something we see even in our patients' lives. Once you guys are rotating in hospitals and stuff, you'll see that as well. In fact, like with spinal cord injury patients, I remember learning the stat that male partners are going to be more likely to leave their like injured female partner than the opposite way. So it's something that you can see even here, and it can be very devastating for your patients, right? If somebody's partner leaves them, and a lot of the times they're in inpatient rehab for like weeks on end, more than a month. So that could be something that really deeply affects them, and again, it plays into how much they participate and overall how their function is. So those are big things to consider. And also with the psychosocial aspect, like I would say from a physician standpoint, we care a lot about somebody's support system. Like it's one of the questions that we ask when we admit people is like, what's your support system like? Who do you live with? Who are you going to go home with after this? These things are huge because it impacts like, where's this patient going to go? Are they going to go home? Are they going to go to like a subacute rehab or a nursing home? Where are they going to go after this? And then patients with better support systems, a lot of the times they can actually have like better outcomes just because they have those people who are, helping them, getting them to the appointments they need to go to, really checking the things on their list that have to be done. So it's like it's huge. Your support system is huge. And if you have that, it can make a huge impact in your recovery. And if you don't have that, and somebody, if somebody's not like as self-motivated, or if they have an injury that impedes them from advocating for themselves, like if somebody has a traumatic brain injury, they can't necessarily advocate for themselves. They might not be able to in the way they would have before their injury. So that support system is so crucial, and it plays a huge role in our field. Did the article mention about each person's support system? I don't think I didn't read it in detail, but from what you were saying, Nora, it sounded like not necessarily.
Yeah, it wasn't it wasn't in depth like that. It was a lot of, for the results section, it was looking at a lot of different, there was multiple quotes for each section, and it was kind of just highlighting those. So it didn't get to look at specifically the support systems. It was just gathering the major themes from across all the interviews. So yeah, unfortunately, we didn't get to see that, which would have been very interesting to see as well. I'm sure they would have had some similar experiences, but yeah, that's something that we missed out on.
Thanks so much for answering that. Oh, I keep interrupting you. Go ahead.
No, it's okay. I was gonna say, should we jump to the third article?
I think so. If you want to start, Jennifer, screen sharing, but I do just want to acknowledge I appreciate the connection between what we're seeing in the article as well as what you see in practice, Dr. Mahfouz. I mean, I think
Oh yeah.
that's an insane statistic, a very devastating and unfortunate, but I think it's something that when we're as students going on rotations, I think that's something that we really have to keep in mind as well.
Right, right. I like the global aspect, but of course, I can only think of like, it makes me think of like what I've seen. And of course, I've only seen
Mhm.
what's done in the US. And I want to say thank you, Nora, for the article as well. And I liked how it highlighted like specifically women's struggles with disabilities.
Thank you.
Mhm.
Yes, thank you, Noor, for answering my question. Yeah, and thank you guys for bringing light to like this topic, which is at the forefront of a lot of international like events that are happening. And I think that the most emergent care, like emergency or surgery, is kind of what people initially think about, but putting the pieces back together is kind of things that is not really thought about as much. So thank you guys. I have a topic that pivots a little bit, and it's focusing on, well, it's similar in the way that it talks about more interview style conversations about delivering rehab around the world and looking at from different practitioners and their topics. Oh, and I'm Jennifer Zhu. I am a rising OMS 2, and I go to Toro at the Middletown campus in New York City. And thank you to the JEDI community once again, and thank you all for being here and listening to this conversation. I'm very interested in like different cultures and like how like everybody has their own take on things. So this was a very interesting read for me as well. And Professor Ducat arranged like a great collaboration with many different organizations as we can see going forward. And so before we go in, some abbreviations to keep in mind is like PLD is going to stand for people living with a disability. And I think we all know who is, but just in case, I'm just going to put that out there. And so a little background on my presentation for this is just like over 2.41 billion people worldwide could benefit for rehab, and it's kind of like as expected, like there aren't as many systems in place to support that many people that need the rehab that they would require, and there's not enough trained or skilled workforce members to reach the need. And the UN recognizes that all people should have equal access to rehabilitation. It should be a basic human right, but like many things with government and bureaucracy, things have not been implemented in a timely manner that would be beneficial to a lot of people. And the scale of the problem is kind of the reason why a lot of these conversations are continuing and like understanding why these gaps in rehabilitation exists. And so oftentimes whole system solutions are best case scenario, but as we often see, there's a lot of like either community-based support that happens or just like you get what you get, and then you have practitioners who just have to wear multiple hats, which we can also see in American healthcare systems as well for like PCP or family practice. And this study in particular adds like the provider's perspective. A lot of the times you see people interviewing from the patient's perspective, but this one was very interesting because you heard PM&R people who are in leadership and their understanding of their systems. And so that helped kind of created more of like a top down as well as a bottom up with a more holistic view of things. And the objective was to mainly identify challenges and common issues in rehab care and use those experience to kind of go forward to improve like rehabilitation for a more international global population. Because from what I know, and I've just entered this field, is that a lot of what I understand of rehab is from a first world country in America. And so, like, looking from this perspective gave me a lot of insight into what other communities might be experiencing and how you could service them in the resources that they have. So this cohort took 30 opinions, 30 rehab opinion leaders from 24 different countries. As you can see, they kind of broke it down into this divide. So, different regions. So we have Africa and the regions of America, Southeast Asia, as well as Europe, Eastern Mediterranean, Western Pacific, and just took a lot of different regions as well as bracketing into like socioeconomic. So low income, lower, like I assume they use GDP to distinguish this, lower middle income, upper middle income, and high income. And between, they didn't choose only PM&R physicians, but also rehab nurses, physiotherapy, OT, speech language pathology, epidemiology, and public health workers as well. And so the breakdown of the method was to ask three main research questions, or they, I'll go more into the formation of these questions, but the three questions that they narrowed to was what workforce/human resource issues contribute to rehab disparities in low resource and rural settings. The question two is what local strategies are being used to improve rehab workforce sufficiency and development. And question three is what historical, cultural, and socioeconomic factors are shaping rehab service delivery. And these were mostly conducted over Zoom interviews using standardized pilot tested protocols with informed consent, confidentiality protections, audio transcriptions, and written summaries. And so, how they ended with these questions was initially, they used the framework method to take all of the responses and found overarching themes. And after they identified these common themes, they generated these research questions and essentially sectioned each of the interview responses into these questions and created these common responses. So it was kind of averaging these interviews and sensing what was commonly spoken. So some of the common themes for question one was insufficient workforce. Rehabilitation is not funded properly, but needs to be. Or it's not a priority because there's other healthcare services that are given priority. Disparities of service are reflected based off of income levels and geographic regions. Like remote and rural areas have little to no service. What local efforts, for question two, for what local efforts are underway to improve rehab workforce efficiency? There's a lack of awareness, and the government doesn't really know what rehab is. And the success stories of people fighting for rehab are growing, so people are becoming more aware. And as we have previously mentioned, that it's a fairly new field, so there's a lot of education that needs to go in on a global scale as well. But it's a good thing that people are now knowing more about it. And then the third one, which is what critical factors, including historical, cultural, socioeconomical, are affecting the delivery in local healthcare system, which is stigma is very real and impacts a lot of people's willingness to go reach out for rehabilitation care. And that could include history of like rehab professionals, the inability to pay for services, and cultural beliefs of undervaluing like people with disabilities and inability to travel to receive rehab services. Um, and here are just some excerpts from the table that this article provides based off of the answers to these questions, where essentially, like, these practitioners are explaining some of their experiences navigating the field, where addressing for question one, where it's about addressing workforce and the ability to kind of gather resources for underserved people. It's just like it's hard for if you have 115 million people, but you only have three rehab physicians and like a small team that they all oversee, it's very, very hard to provide everyone the care that they would need in order to have the best possible recovery. And another practitioner was experiencing just an issue with traveling where they had, I believe it was in a Asian country where they had 17,000 islands to cover, and you would need to reach them by helicopter. So, for those people to consistently receive care, it seems like a very, very hard feat is an understatement. And there's also a preference for private-owned rehab uh, facilities. And so it's if somebody has the money to pay for rehab, they will get it. But um, if you don't have the money, the facilities are just very far and few in between. And as a result, it's just not possible to service those people in rural or hard to reach areas. And the question number two is just like what local strategies are being used to improve the rehab workforce. And it seems like people genuinely want to better train or have a way forward to train their personnels in order to gain the ability to help people. Um, some people complain about there's no national guidelines because the government doesn't really know what rehabilitation care is. Um, and then, or it's like there's people who just have to wear so many hats. And so PTs are sometimes forced to do occupational therapy, but they just don't have the training to do it. They just do it based off of what they think they know. And every rehab worker is also a general practitioner in a lot of parts, especially for underserved communities. And there was also a case where there are state-of-the-art facilities, but the healthcare workers themselves do not have the education and knowledge to how to use the machines properly. And that is a huge barrier into entry to providing adequate care for the populations that they work for. And for the third question, which is what historical, cultural, socioeconomic factors that shape the service delivery, is that rehab doctors are invisible to certain healthcare systems because people living with disabilities are invisible to the societies that they live in. And there are old school physicians that do not believe in rehabilitation. And another mention of the government not understanding, as well as some cultures see that people with a disability are seen to be have been cursed, or it's a punishment for things that they have done and should be excluded from their communities. And this is kind of where I want to introduce another like article that I was interested in covering, but I thought it would actually be more better as a supplement, where these therapists in South Africa were talking about this rural population in the KwaZulu-Natal people. And they found that in certain cultures, like they have strong beliefs about like curses and bewitchment, which is hard to kind of explain in medical terminology. And when there's misalignment between how the medical practitioner understands things and how the people that you're servicing understands things, that can lead to a lot of distrust. And the stigma with disability and how these people should be abandoned rather than taken care of can perpetuate the lack of care that they receive. And they've also observed that some people with disabilities struggle to obtain transportation, which is already very limited because other people of the community avoid them due to beliefs that they might also catch a curse that this person may have received. And so this further emphasizes the education and cultural um, the education on rehabilitation literacy, but also being culturally conscious about the people that you're talking with and understanding what their main beliefs are and integrating teaching with things that they can understand and work together in order to help everybody in their community and kind of dispel beliefs where things could harm other people and try to make things like more accessible for people through these educational initiatives and work together with these communities instead of just inserting what we know and providing established care that we learn kind of in our education and rather have them teach us how best to help them. And going back to the main paper that I was talking about is that yes, there's a high demand for rehab, and the main problems are access barriers, lack of funding, lack of workforce training, and having other medical priorities kind of at the forefront, which is understandable, but there should be a awareness of the importance of how important rehab can change a person's life as well. And apparently retention is a major challenge as well because these professions are not very highly paid, and so there's a lot of brain drain in these countries where these providers don't feel like they're being respected or treated well enough, and so they leave to go to countries that they feel like understand their profession a lot better. And so, and to reiterate, these people living with disabilities face a lot of barriers, whether it be cultural, geographic, socioeconomic, and those barriers need to be kind of addressed a little more like focally in those healthcare systems. And so essentially, this is just kind of a snapshot, even though they took a lot of different leaders' perspectives. They are just one voice for many different countries, and I wouldn't say they would fully provide an explanation for everything that is going on for every community. And so I think what we can see is just like rehab can't be generalized, and the more studies, the more communications, the more understanding how different people understand rehab and reaching out to them at their level is what we can do best in enhancing both the service delivery, but also the education of the benefits of how rehabilitation can positively transform somebody's life. Um, and so conclusions essentially is there's no one size fit all approach. And so we have to really work with, I think each community needs to work with each other, but I also see the benefits of like international communities coming up with programs to kind of help tailor the introduction and education to rehab. Like I would love to hear how everybody's ideas on like addressing this. I think like this opens a lot of conversation for how different communities can like engage specifically with their own populations, but I also can see how it can provide a way for people in different communities to kind of like share notes and compare and see like, oh, if this worked for me and like share ideas to better help each other. And instead of like saying, oh, we need one size fit all, create a network or even a web of communication to better support and uplift these communities that have these like holes in their care for rehabilitation. And here are my references.
Thank you so much, Jennifer. I have so much to say about that, but I learned a lot. And I do want to acknowledge, I know we are over time. So just to respect everyone's time, if you need to go, please, feel free to head out and have a good night. But if Dr. Mahfouz isn't mind, just hang out a few more minutes. If
I
anyone
don't
would like
mind
to
at all.
continue, perfect. Okay, I was hoping you'd say that. Um, we would like to continue the conversation for a few minutes. And I, real quick, do want to acknowledge Nathaniel's um, comment about having more qualitative articles today. Yes, I agree with you, Nathaniel. It's important to value these sort of articles and not just focus on the stats, and instead also value people's voices and appreciating the value. So, Nathaniel, thank you so much for your comment. And Dr. Mahfouz, I will hand it over to you.
Oh yeah, that was actually one of my like thought processes. I know that yeah, like Nathaniel was saying, these articles could be considered like weaker, but I do think there's value to them. And I actually really like this article because I like that they spoke to like individuals who are in the rehab field in different countries, and it gives you so much good perspective. Um, a word of advice I was given once when I was giving a presentation on global rehab was to talk to people who worked in this field. And I talked to two people I remember, both Americans, but they've worked in, one of them had worked in Tanzania, and then the other one had worked in like sub-Saharan Africa. And I think he was doing work in South Africa, I think it was. But essentially, I learned so much from just talking to those two individuals and their experience in the like expanding rehab to other regions of the world. So actually, I really like this article because it talked to a lot of different specialists from all those areas. And I think there is, even though it's not like a randomized control trial or something like that, there is still a lot to be learned from those kind of studies. That the one place they mentioned that had 115 million population, but then they only had, I think, two physiatrists and like 17 speech therapists, and that was crazy. And then I also appreciated something the article that it mentioned was the cultural awareness and cultural sensitivity. So I did want to highlight a couple of things. One of the docs I spoke to, like one of the American docs that I spoke to, her name was Dr. Eason, and she works in New York and Columbia. She's a physiatrist, and she worked in, I believe it was Tanzania that she had told me. And like so that was something she mentioned, like the importance of having like that cultural awareness. And even aside from that conversation, just through my reading, you don't want to go to you don't want to go to another country and be like, oh no, but your beliefs aren't right. Let me show you what's actually right and what you should actually believe. That's not good. So, you want to have that awareness when you're going to these areas. Um, I think I think one of the docs I spoke to, she was trying to work on building an inpatient rehab. And she was telling me how she was working with a therapist. One of the barriers she had mentioned to me was that a lot of people don't understand what physiatrists do. So she would say she would show up, and again, this was Tanzania, and they would think she's a physical therapist. So they'd be like, oh, so maybe you can, you know, work on my low back, and they'd expect her to do like PT stuff, but she's like, no, I'm not a physical therapist, I'm a physician. So there's a lack of understanding, which is a huge barrier to like physiatry specifically in other parts of the world. And then a lot of people don't think our field is very like life-saving or important, especially in, I would say more so in disaster settings than in like non-disaster settings. Like your article was more focused on non-disaster settings, but like in disaster settings, our field is not considered like life-saving. Although, and it's not like a surgeon where like, oh my God, somebody's, their limb is hemorrhaging or it's infected and you need to amputate immediately. Nobody's calling the PM&R doc. It's not like that, but we do have like important roles that we play immediately after. And I do think you kind of touched on this as well, Jennifer, that there's like a time sensitivity to a lot of these things because, for example, with an amputation, some of the complications you want to prevent like contractures, you want to prevent like deformity in like the residual limb. You want to make sure things are going well so that they can get fit for a prosthesis, and then continue on their care from there. So there's like these things that are time sensitive that if you wait too long, maybe they develop a contracture or they develop a wound or whatnot. And then like these things can complicate their overall recovery process. So these are things like to keep in mind. I wanted to mention this one of the doctors I spoke to, who's again, an American physician who worked in sub-Saharan Africa, something he told me that was so interesting. He told me that he refuses to basically treat any patients when he travels overseas. And he's like, I don't treat any patients. And I was like, what do you mean? And he said, his mentality is he wants to train physicians in that area to be able to carry on the skills and so that they can treat, their own like country folk essentially. And, I thought about it and he said, because you don't want to like start somebody's treatment process and then like just disappear essentially. Because that's what happens with a lot of these docs that travel to specific areas of the world, and they do, even surgeons, like they'll do a surgery and then poof, surgeon's gone, right? And then it's like, okay, well, what about the recovery process after the surgery? What if there's complications? So he was saying he doesn't like to treat patients himself because it's a longitudinal process, and he doesn't want to just be there to start something and then not see, the follow-up. There's going to be maybe complications that arise. Maybe this patient's mobility device that you prescribe them, maybe it's not working for them, or it's not fitting properly, or whatever it is. And you're not going to be there. You just disappeared. And now they're stuck with this equipment that they don't know how to use or whatnot. So I thought that was really valuable. He actually started a like fellowship program. And he's doing like a 2-year training program for different physicians in, I think the most I've seen on his website was South Africa and Ghana. And he does like a 2-year PM&R training program essentially. And he teaches them like, basically it's literally like a condensed PM&R residency. And he's teaching them all these skills. And I believe he told me he teaches them like EMG, and management of like spinal cord injuries, brain injuries, that kind of thing. And his whole idea is he wants to teach these doctors so that they can carry on this work and like really, provide that longitudinal care that patients need. And I remember talking to him and thinking, wow, that's brilliant, because ultimately that's really what's going to lead to long lasting change, more so than like you or I traveling and helping somebody for a week. You know what I mean? So that was like something very remarkable that I remember learning from him.
Yeah, that's so fascinating. Yeah, and then it's also like you teach a man to fish and he will be fed forever.
There you go. There you
Yeah,
go.
and also like it provides such a like sometimes when a stranger comes into a community, there's some distrust, but like if you have people who are they're familiar with, it's like, oh, this is a very strange thing, but
Mhm.
the doctor that like saved my life is telling me this is good. And so the barrier of the I guess the reluctance is decreased because
Mhm.
of the increase of trust, which is oftentimes a big factor of somebody who's has good intentions but doesn't know how to deliver it. So I think that was so interesting.
Yeah, no problem. No problem. Yeah, I remember learning that, and it changed my mindset because I've always thought like I want to go, because I've always wanted to. I'm Palestinian myself, so I've always thought like, oh, I want to go to Gaza one day, or to Palestine in general one day, and like maybe help people. But like I've always wondered what that would look like and how feasible that is. But when he said that to me, I was like, oh, that's such a different way of thinking of it. Instead of like, oh, you're gonna go for a week. What if you teach people how to manage these conditions so that they can do it long term? It changed my mindset. Yeah.
So if we see a Dr. Mahfouz run
Residency
and
program,
residency program, then we'll know where it
then you'll
started.
know. You'll know. And then the last two things I guess that I'll mention, and please, anybody feel free to drop comments, say whatever you want, interrupt at any time. I did mention that a lot of people think like rehab is not essential, and it's not life-saving, but even in like in disaster settings and even in non-disaster settings, a lot of the things that we do can actually prolong people's lives. Okay, like I said earlier, you're not saving someone's life acutely, but like it can prolong people's lives. There's complications that people die from after they have like a catastrophic injury. They can die from like a skin infection. They can have like a wound, especially like a pressure injury. If they're not being turned regularly, they can die from that. They can develop urinary tract infections. They can develop, you know, different medical complications essentially. And a huge part of rehab is teaching patients how to manage these things, like how to manage their skincare, how to manage their like bladder and bowel care to prevent these complications. And that can ultimately be life-saving in the long run. It can be. So I always think about like disaster settings, and I think, okay, like, yes, you're not saving this person's life, but um, rehab docs, we do have a huge role in preventing medical complications and ultimately leading to not just a better quality of life, but potentially like, yeah, like longer lives as well, in a sense. So it's something that's super important to think about. And then another thing that I wanted to mention, I know, was it Shreya, the first person who presented? I do know one organization, it's called Gaza Health, and it's an organization that does essentially telemedicine for people. Like it connects physicians in different parts of the world to people in Gaza. And they do have like, I think they do have like musculoskeletal conditions as one of the things you can sign up for. But they essentially provide consultations to those people virtually, to people like patients in Gaza with physicians in the US or anywhere in the world. And then you can prescribe meds, and then they're even connected with local pharmacies in the area, and patients are able to get those medications that they need. And it's an incredible organization. I don't know the numbers off my head, but they've delivered medication to so many people in Gaza, and they've set up many virtual appointments. It's a really cool organization, and it's a way to help. And they do have like they do have like if you sign up on their website as a physician, one of the things I do remember was like rehab or musculoskeletal disease. And you can help with that. So there's opportunities out there. It's a very cool organization if you ever want to look into it. Any questions, comments, concerns?
I think Kirti had a question in the chat for you about, I was just quoted. Does some of that ability to prolong life through rehab have to do with the focus on quality of life as well and mentally? Like, is that something that's seen in outcomes?
Um, I don't know off the top of my head. Like I can't say I don't have like a data point that I can say that for sure as a thing that like, oh, rehab can improve quality of life and people's mental health, and that improves their lifespan. I don't have like a data point that says that. Um, so I can't say definitively, but I was thinking more so by like reducing medical complications. I want to say just anecdotally, like I feel like if you're improving people's quality of life and their mental well-being, that does, at least at the very minimum, we can say that I don't know if it can prolong someone's lifespan, but it can give somebody a better life ultimately. But that would be something to be studied, I would say.
Are there any other questions, comments, or concerns, everyone, before we wrap it up for the night?
I guess I have one quick question. Is like,
Yeah.
I don't know like if anyone has gone to like the ISPRM conferences, but I have not yet. And I'm wondering like if they have these kind of conversations about like addressing different cultural approaches at the like meetings and like what the general vibe is.
I've actually never gone to any of their conferences. I've heard of the organization, again, like when I was reading in the past, because they did work in Pakistan after the 2005 earthquake, if I remember correctly, but I've never actually gone to their conferences. So I wouldn't know how they're, but it's an international, isn't it stand for, isn't the first word international something?
Yes, yes.
I would imagine that they have some kind of cultural competency, but I've never been to a conference, so I can't say.
Thank you so much for bringing that up, Jennifer. Actually, now I'm interested in going. I think it's in New Zealand. So
Oh,
AOCPMR group trip. But really, if anyone else has anything, thank you so much for your time. I can't thank you enough, Dr. Mahfouz, Jennifer, Shreya, Noor. Thank you for taking the time to dive deep into these articles and teach us something. I learned so much. This is going to be recorded, so if we ever want to learn some more, you can. Oh, perfect. Zed,
I,
go ahead.
I put my email in the chat, so if anybody wants to reach out, feel free, please. If you missed the chat for whatever reason, you can tell Aya and she can tell you how to contact me.
Right. Well, thank you. All right, everyone,
Uh,
you have a really great night. Really appreciate everything.
Thank you to the presenters. You guys were great.
Thank you.
Thank
Yep.
you,
Thank
guys.
you.
Have a good night.
Bye.